Assalamu alaikum to all. Should we start? أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفر إنه كان توابا صدق الله.
Jazakallah. Assalamu alaikum and good morning to all of you. I welcome you to the 5th hands-on ERCP training course. Alhamdulillah, we have successfully completed 4 ERCPs and 9 hands-on colonoscopy training courses. And our 10th colonoscopy training course is scheduled in March. And all this is made possible because of our faculty and the trainers that we have. We are very fortunate to have exceptional and outstanding trainers or the faculty for the course. They are all leading names in their respective fields, big achievers. I would like to introduce faculty, international faculty first. We have Dr. Waqar Ahmad. He's a consultant gastroenterologist, previously working at Gannad Hospital, Bangor. Now he's been recently appointed as the consultant gastroenterologist at North Manchester General Hospital in Manchester, UK. He's also a trainer for the colonoscopy course, an excellent teacher and a wonderful person. Thank you, Dr. Waqar, for coming. We have Dr. Muhammad Khalid Hassan. Dr. Khalid is working at the prestigious position of Director, Advanced Endoscopy Fellowship Center for Interventional Endoscopy. He's also Assistant Professor of Internal Medicine at University of Central Florida College of Medicine. Thank you very much, Dr. Khalid, for coming. Dr. Tariq Mahmood, he's pioneer in the field of cyber knife technology in Karachi. He's professor of radiology at Jinnah Post Graduate Medical Center. Then we have Dr. Saad Khalid Niaz, who is a leading name who doesn't need introduction as such. That's what I feel, but he's Director Endoscopy at Surgical Unit 4. He's backbone of the endoscopy service that's established in Civil Hospital, Karachi. I would now invite him to please, before that, I would like to invite a person whose vision has made possible to have a state-of-art unit like Surgical Unit 4 in a government sector hospital, a person whose guidance and whose encouragement has made all these academic activities possible in this unit and whole of Karachi, in fact. He's chairperson, Department of Surgery. He's Professor, Surgical Unit 4, Dr. Saeed Qureshi. Sir, can I request you to please come and say a few words?
Sure. Thank you. Assalamu alaikum and welcome to Surgical Unit 4. As Sajda has pointed out to you, this is the 5th ERCP hands-on course. And I think the 9th, we have done the 9th colonoscopy course. We have done the 9th colonoscopy course recently and are heading for the 10th course in 2 months' time. It was the idea of Dr. Saad that we should have this hands-on course, and with the able support from the United Kingdom. Originally it was Waqar plus other people from Liverpool who were speaking on this course, who actually developed this. Waqar had trained at Liverpool, was teaching at Liverpool, and knew the nitty-gritty of how to train people for ERCP. Khalid has joined us. This is, I think, the second time, or the third time that he is here. And he is an expert both at ERCP and more so at endoscopic ultrasound. And in the future, we hope that we will also have an endoscopic ultrasound hands-on training course. I'm grateful to both of them, to Saad for being here today, and you will be seeing them over the next few days. You won't be seeing much of me since I'm in and out of the ward most of the time, doing administrative work mainly for the health department. So anyway, I hope you have a good time, and at the end of the day, I hope you have learned the finer points of how to do an ERCP. Thank you very much.
Thank you very much, Dr. Said. We all have dreams, dreams of excelling in our respective fields, dreams of becoming better than our peers, dreams of becoming best amongst all. And in order to make these dreams come true, we need to put in lots of dedication, hard work, and self-discipline and effort. And these workshops are conducted to give you an opportunity to learn the correct things, to learn the best from the best amongst the trainers who are available right now. So make most of this opportunity and live your dreams. That's what I would like to say to you. Now I would like to request Dr. Saad Khalid Niaz to please come and give a brief introduction of the course and introduce the participants.
Bismillahirrahmanirrahim. Thank you very much, Sada. Yeah, it's all about dreams. This whole unit started with basically just an aim to provide ERCP facilities, to be honest, way back in 2006. So we've done 10 years of endoscopy service in this unit. The dream was to just start with ERCPs here. They were not available in the public sector. And then it just moved on. And from just providing ERCP services, we just went on and on and on. And today, I can proudly say that we are probably the most advanced unit there is in this country, whether in the public sector or private sector. We do about 1,000 ERCPs in this unit a year. And our success and complications both are as good or as bad as any good center in the world. We take pride in the work we do, in the quality of work we do, and above all, everything done in this unit is free of cost. Obviously, there's a lot of hard work that's gone behind this, and like Sajda rightly pointed out, the credit really goes to Professor Saeed Qureshi for actually setting this up, allowing somebody like me to come over here and basically start something that now is a reality, far more than what we actually dreamt of. So, like Sajda said, you can start thinking, and once you start thinking of, high achievements, the chances are, and you work towards them, you are likely to achieve them, inshallah. When we did this, we started running, training, which was very in-house training. Started ERCP initially, and now we have 5. One has left us, so we've got 5 people who are doing ERCPs in this unit. And they're all very good, alhamdulillah. And then the thought was, how do we help others? Because we are limited in terms of people that we can take. And UK started these courses some way back in 1999 or 2000. They used to do these hands-on courses. very extensive 4-day courses. And so we decided that we should actually try and see if we can do them here. And fortunately, with Waqar's help, we were able to actually get the same curriculum, same program that they were doing back in UK. And so this course is exactly the way it's done in UK. Maybe an ERCP, you get one ERCP more, and we have one more candidate. So generally in UK they have 4 candidates, we have 5, yet we end up giving you more ERCPs than they do in UK. So the idea of this course is to actually, like Sajda said, to give you the basics. If you have the right basics, the right foundation, you're going to build it up, and then hopefully whatever you achieve, it'll be in the right direction, the right way, and the right method. You're here to learn, and I know you come from different units, but please pay attention to what your faculty is saying. I know you come from big units, which we'll find out in a minute, but we don't want to know how, we don't mind knowing how you do it, but here we want you to know how we do it, okay? And you can go and see whether it makes a difference. We have pretty standard methods. Most people do it in the same way. So pay attention, be here on time. There's one gentleman who was not on time here today, and we had to wait for the gentleman, and so I would expect and hope that you're going to be here before the faculty. And Khalid just arrived yesterday evening, Waqar arrived early morning. So if they can be here on time, I'm sure all of you can be here on time as well. Now, what we generally do is we've introduced ourselves. We want to know who you are, which unit you belong to, what you've done, okay? Just so that we know where you stand today. And so what I'm going to do is ask the hands-on candidates. Let me make it very clear, the observers don't get any hands-on experience, period. Okay, so that's something that you should know right now. We cannot give you any hands-on experience at all. This is just for you to see. You get to see 25 ERCPs done under supervision of some of the best people. The good thing about this, slightly different from UK, is that you have a taste of UK, US, and a little bit of Pakistan, but I mean, you know, I'm basically UK trained, so yes, some Pakistani perspective of what I've learned here. Ahsan Rahim, Dr. Ahsan Rahim. Okay, can you tell us, aap kahan se hain? How many ERCPs are done in your unit, and how many have you done under supervision or whatever?
Assalamu alaikum. I'm from Israel University Hospital. I'm working as assistant professor in gastro department. Alhamdulillah, I have done almost 40 to 50 ERCPs under supervision of Dr. Amar Guri. Actually, we have a more candidate which in learning phase in our department. So we have not so much cases for learning. So, after that, still I have reached the ampulla, and I have also successfully cannulation done, about 5 to 6 cannulation I have done. And meanwhile, I have passed one stent, and I have done one case of sphincterotomy, and unfortunately I have done sphincteroplasty.
How many ERCPs are done in your unit in a year? Approximate, अंदाज़न.
Approximately we have
महीने के कितने
महीने हफ्ते में 8 ERCPs तो हमारी होती हैं.
Good.
8 से 10 ERCPs हो जाती हैं. सारे आमर गोरी के सारे केसेस होते हैं तकरीबन, because Dr. Ali Akbar Siddiqui has left just now to abroad for about 3 to 4 months, तो इस वजह से केसेस थोड़े कम हो गए 4 to 5 months.
How many trainees do you have doing ERCP?
We are 4 assistant professors in department, so we all are in learning phase as an ERCP.
4 assistant professors. What
assistant.
about the fellows?
Fellows are not in learning phase of ERCP. They are not allowed
They are
for
not
ERCP.
allowed.
No.
Okay, good. Dr. Shahid Mahmood. For Shahid, you have to be on time from tomorrow.
Okay, sorry, sir.
Because you will be penalized, I'm sorry.
Okay, sir. I'm Dr. Shahid Nabud. In the recent past, I have done many ARCPs under supervision of Dr. Lubna Kamani, Dr. Kamrul Arfin, and Dr. Tayyib Usmani and Dr. Zahid Azam. I worked at Liaquat National Hospital where I did ERCP with Dr. Lubna Kamani, and when I was in Ziauddin Hospital, University Hospital, I did ERCP with under supervision of Dr. Kamrul Arfin. And when I was in Dow University of Health Sciences, I have done a few ERCPs with Dr. Zahid Azam and Dr. Tayyib Usmani as well. Now I left Dow University of Health Sciences for some reasons, and now I am in National Medical Center. Over there, we have Dr. Kamrul Arfin, Dr. Lubna Kamani, Dr. Ashfaq Ahmed, and hopefully I will do ERCP with them.
So you're not in a training program anymore?
No, not now.
Okay. This course is basically for those who are learning, okay? And we expect you to go and continue doing under supervision. Please don't think that after 4 days you will be independent and ready to do whatever you have seen being done here. We just want you to know, learn, build on it. This is not, this is a basic hands-on ERCP course, not an advanced ERCP course. So you must continue doing, and we'll give you a feedback whether you're safe and how safe you are if possible. Waqar and Khalid, you can tell them. Majid Sumro Saab.
I'm Dr. Majid Ali Sumro. I'm assistant professor in medicine and gastroenterology at Liaquat University. Initially, we used to do ERCP at our center. When Dr. Zulfikar Bhatti was with us, he left. Since then, we are not doing. I'm doing in private sector along with Dr. Sadiq Memon.
So you're with Sadiq Memon?
Sadiq Memon, yeah.
Okay. So how many ERCPs have you done so far?
Assisted, I have done 10, 15.
Assisted?
Yeah.
You haven't done, under supervision, you've done completed, cannulation, what?
Cannulation, guide wire, and then it was taken over with.
Okay. Hafiz Mughis Athar.
I am assistant professor gastroenterology in Punjab Medical College, Faisalabad. I attended the hands-on ERCP course in Bangkok, where I did under supervision about 80 ERCPs in 3 months. Now I am doing ERCPs with Dr. Shahid Rasool in Faisalabad.
Okay,
we are doing together.
Okay, Shahid is one of the candidates, one of the first few, I think second or first course, I don't know, he was with us.
So we're doing private setup in our hospital, the teaching hospital. We are in the process of building up the setup for this.
You have done ERCPs yourself?
Under supervision, we do together with I and Dr. Shahid Rasool.
So are you actually intubating?
Yes, intubating, stenting, and yes.
You're doing, how many have you cannulated so far?
About 10 to 15.
Okay, this about 10 to 15 is a very interesting thing. At this stage of your learning, no matter what level you are, if you're learning something, you need to know how many you've done. Yeah. I think it's very important to know, whether you've done 10 or you've done 15. It's a 50% increase. Makes a lot of difference. So I think it's important to know exactly what. Barum Kumar. Barum, you're from Nepal.
Yes, I am from Nepal, and I'm doing my final year training in Mu Hospital. As everyone know, like there's no ERCP going on over there. Initially, I did in Shekhzad Hospital for 3 months. I was just observer over there. I was doing with Sad Kamal Bhatt sahab and Kasib Malik sahab and Zohar Amin sahab. I did for 3 months. And then I started in private setup where Dr. Muhammad Irfan was doing. In our center, like sir, till now, we have done more than 500 cases. And weekly, around 10 to 12 cases has been done over there. And personally, I have done around 18 cannulation independently. And sphincterotomy, even I have done stone extraction little bit. And I have done.
What do you mean by little bit?
A little
You've
bit.
either done it or you've not done it?
No, few cases I have done.
Or you took little bit out and left the rest for the others?
Means few of them I did by myself. with assistance, and then I did around 55 to 60 ERCPs.
Okay, good. We'll find out tomorrow who has done what. Okay, that was the hands-on. So we also have observers here. Dr. Abdul Qadir, quickly, which unit are you from? And so he is not here. Oh, sugar. Sab khairiyat hai? He's not hurt or anything. Okay, Saad Razak.
I am doing my fellowship at Ziauddin Hospital. I am currently in the observing phase of the ERCP with Dr. Zaigam Abbas and Dr. Saad Khalid Nias. So it's just the observation thing, and I haven't performed any ERCPs yet.
Iftikhar Ali Shah.
I'm from Ghulam Muhammad Mar Medical College, Sakkar, working as assistant professor in the Department of Medicine. We don't have any setup of ERCP at Sakkar, so I don't have any prior exposure to any ERCPs.
Nobody is doing it in Sakkar?
Assistant professor.
Nobody is doing it in Sakkar, ERCP?
No, we don't have any setup at Sakkar yet.
Basir Sultan Ahmed.
I just cleared my FCPS2 in gastroenterology, and I have done training from Liaquat National Hospital. I did 35 to 40 positioning of the ampulla, and 2 times I've put stent, and I haven't performed any sphincterotomies. I'm just learning.
Okay. So you're from Liaquat National Hospital?
Yes.
LNH.
Yes,
Karachi. Great. Well, we have some idea. The reason why we want people to actually have done something is because it's very difficult to bring you here and start from fresh. So we expect that you at least know how to handle the scope and all that stuff. During the next 4 days, we'll try and improve on what you already know and correct what we think is not correct in your technique. Do not get disappointed if you're not able to cannulate. This is ERCP, so we will not take a chance with our patient. Just because we need to teach you doesn't mean we are going to put him or her at risk. So the moment any one of us feels time to stop, regardless of whether you are doing the right or wrong, we will stop. And when we ask you to stop, that's it. No questions asked, sorry, take over, because patients' health and patient safety is our priority and should be priority of everyone. So this is a lethal procedure. ERCP, as you would know in the next lectures, is not something that should be taken like upper GI endoscopy. Not everybody can be good in ERCP. Not everybody is good in ERCP. Not everybody should do ERCP. In US and UK, not everybody is allowed to. GI, all gastroenterologists don't. So the fact that you have done your FCPS in gastroenterology does not mean that you need to know ERCP as well as everything else. Okay? So I think you will find out whether you can or can't. Whether you do or not is a different matter, but as long as you're not harming your patients, that's important. Okay? You will be questioned. Maybe not here, especially in this part of the world. In their world, you would be. But you will be questioned in the hereafter. If you're not careful, and if you do something that you shouldn't be doing with your patient, I'm sure we will all be questioned. Okay? Okay, so we'll start with our... Dr. Tariq ki kara le. Okay, so we'll start with slight change in the program. Professor Tariq Mahmood is here. We've already introduced him. He is, heading the radiology department at Jinnah Hospital, Jinnah Postgraduate Medical Center, and now University. Not only that, but he's turned the radiology department at Jinnah from nothing to something that that probably is one of its kind in the public sector for sure, and maybe even in the private sector. So huge department. Latest fame is the cyber knife and many others. There's a long list, but Tariq continues to impress all of us with not only his radiological capabilities, but also his administrative and philanthropic. Tariq, thank you very much for being here. And we'll start with just basic radiology related to ERCP and other. साथ के साइज का बनाया प्रेजेंटेशन हाँ अच्छा Bismillahirrahmanirrahim. I honestly feel honored and privileged to be a part of this training. I think since its start a few years ago. I'll just be talking about modalities and mainly about the X-rays, its properties, and use of X-rays in the ERCP system, right? For the evaluation of duct, you have various modalities: ultrasound, color Doppler, CT scan, MR, MRCP, PTC, ERCP. So I'll be mainly focusing on the ERCP and application of X-rays. At the end, I'll share some other modalities. You see, when you are doing an ERCP, apart from the endoscopy, the other part is the X-ray machine. And you should be very careful when you are using an X-rays. X-rays are basically, these are packets of energy. These are ionizing radiation that destroy the growing cells, that can bring changes in the DNA, that can affect the generations. So you should be very, very careful when you are using an X-rays. There are few basic facts about X-rays: that X-ray travel in a straight line. They are either absorbed in the tissue or these are scattered in the surrounding area. The X-rays, when hit the X-ray film or an image intensifier or a detector, you get an image. And that image, previously we were used to do only the imaging with the image intensifier. The new thing is a flat panel and a dynamic flat panel that gives you a better resolution, even more than 1K resolution, and relatively a less consumption of the radiation. But most of the fluoroscopies are still done on image intensifier. Then there is an X-ray film that has some crystal on both the sides. You see, this is an X-ray film. The X-ray film is made up of polyester. If you expose the X-ray film with radiation, it is absolutely black. If you do not expose the X-ray film and develop it, it is just a plain polyester. And when you place something in between, like patient, you have an image. The important thing for you to understand is that on plain X-ray, you can appreciate only 5 gray shade. This is the most white area on the film, and this is the most black area on the film. The most white area is probably metal, because no X-ray can pass through the metal. So when you develop the film, normally the silver halide crystal, which are pasted on both the sides of the film, when these are exposed to radiation and develop, it gets fixed with this polyester. But when you expose the patient and place a marker in between the film and the radiation, when you develop it, it is all washed away. So on a plain X-ray, you basically have 5 colors or 5 density. The most white area on the film is metal. The next white area on the film is calcium, that is bones. The next white area is fluid and soft tissue. The next, then it turns from white to black,
It's basically this little lighter black area that is fat, and the jet black area is the air. So on a plain X-ray, you can only appreciate 5 colors. One is metal, calcium, fluid, soft tissue, fat, and air. You cannot distinguish between fluid and soft tissue on a plain X-ray. Since it is easy to understand the plain X-ray of the chest, so I'll basically describe this on this film. You see, can you appreciate the lumen of the heart here? No, because the X-ray does not have the capability to distinguish between fluid and soft tissue. You see this diaphragm very clearly. And below the diaphragm, you have a liver. But you cannot appreciate the lining of the diaphragm or the liver. And in case of effusion, you have this loss of diaphragmatic outline and the cardiac outline, and you see a soft tissue opacity. And in that case, you cannot distinguish between liver and heart and other organs, because the X-ray cannot distinguish between fluid and soft tissue. So this is the ERCP image. Naturally, this is something made of metal. The other bit lighter density that is also very white on this area, this is a contrast, right? A contrast is again a type of metal in the form of liquid, right? So we describe metal, anything that has an atomic number more than 50, we say it is a metal. That can be in the form of liquid, that can be barium, that can be iodine, which is injected, or barium that is swallowed by the patient, or it can be iron, lead, copper, silver, everything, anything that has more than 50 atomic number is a metal. So that metal appears white on an X-ray. You cannot distinguish between the various type of metal. Anything that has an atomic number around 20, that appear as a calcium, or it is equivalent to calcium density, that is the bone. Now, if you remove the bone, remove the calcium from the bone, it will also get blacker. But if you have some calcification other than the bones, you see it as a stone and as a calcium density. So the point for you to understand is that first look at the density. Compare the density, whether it is equivalent to bone or it is equivalent to some metallic area. And on the basis of that, you make your judgment. Or it is even lesser than that, and it is equivalent to soft tissue, right? Density is mass per unit volume. If you have a more dense area per unit volume, that may appear relatively more denser. I mean, there can be a density that may be more than soft tissue compared to the surrounding soft tissue, but that cannot be a density equivalent to calcium. And calcium can never give a density equivalent to metal. So it is? HU value, I'm coming to HU value. That is a term used for the CT scanner, right? So on plain X-ray, you can only appreciate 5 shades, whereas on a CT scan, the computer of a CT scan can detect up to 2000 gray shades, right? Plain X-ray can only give you 5 gray shades. The HU value or a gray shade it can be plus, mean the fluid appear jet black on an X-ray, that is CSF, and it gives to 0 to 10 Hounsfield unit value. Anything more whiter than this is in a plus, and anything less whiter than this is in a minus. So on plain X-ray, you can appreciate 5 shades. On a CT scan, the computer of CT scan can pick up to 2000 gray shade. So that's the superiority of the CT scan, that CT scan can appreciate between the wall of the heart and the lumen of the heart, lumen of the vessel, right? Because that it is not limited to that 5 gray shade. It has a capability to further clarify, and the clarification is 2000 times better than a plain X-ray. So this is a plain CT scanner, right? This is a contrast enhanced CT scanner where you see a lesion here. This is the arterial phase, this is the portal phase, and this is the equilibrium phase. So with the help of contrast, with the help of more gray shades, CT is much more superior than a plain X-ray. But again, it has its own limitations. So you have to have other modalities when it is needed. Coming back to X-rays, X-ray, what is the term? Attenuation. Attenuation means weakening out of an X-ray, right? When the X-rays are produced in an X-ray tube or a generator, it comes out of the tube and passes through the air and then hit the patient body and then pass out of the patient body, right? So depending upon the density, if a tissue is very dense, naturally it will either absorb or it will restrict these X-rays, and the less number of X-ray will pass through that area compared to its adjacent structure. Again, it depends upon the atomic number. If it has a higher atomic number, it will restrict more X-rays. It will not allow the X-rays to pass through that area. Photons, as I said, these are basically packets of energy. You can increase the energy of a photon also, right, by having a higher MAs. The X-ray that is transmitted through the patient's body that hit either the film or the image intensifier, and then you have an image. Now, the X-ray that is basically that pass through patient's body and go straight up to film are only useful X-ray. The rest all is just a waste, or it just add a, say, fog or graininess on the film. So the useful X-rays are only that are produced in a tube, passes through patient's body and hit the film. The other X-ray that is either absorbed or scatter. This absorbed X-ray does not affect the quality of the film, but this scatter X-ray, which does not go straight up to the film, that just produce fog on the film, right? So that's why we need a very thin layer of a film-like material, and that is called a grid, to remove this scatter X-ray to have a better quality of the image. Again, the X-ray that scatter back, this X-ray is very, very harmful for the doctor and the staff who are basically present in that room. This is the good X-ray, useful for the image. These X-rays just give a dose to the patient, right? Does not contribute to the image. This X-ray is basically also, to some extent, it's scattered, also goes to the persons who are present in that room, but this X-ray is more dangerous compared to that. So X-ray follow the inverse square law, right? If you have this is an X-ray source and this is the plate. If you bring this plate close to it, you will have a smaller image, and if you increase the gap, you will have a larger image. But when you increase the size of the image, naturally, the quality gradually gets down. So you have to adjust your tube according to your desired image. Now, there are two types of X-ray tubes. This is an X-ray tube that is our couch, and you have a image intensifier or a detector here. Now, in this case, there is a possibility of a radiation, and this is the scatter radiation that can harm you, so that's why you need to have a thyroid and other shields. This is the side view. Again, our tube, X-ray is coming from this side, and it will scatter in this direction. So you have to cover your body from this area to this area. This is an X-ray machine where X-ray tube is here and image intensifier is on the upper side, right? So in this case, this is the scatter area, and this is the side view of the tube and the scatter area, right? So in this, where you have a tube under the couch, the radiation usually go to the lower side, whereas if it is over the couch, the radiation is more towards the user's body. So that's why you need to have that gives you a liberty to do liberty to have a easy procedure, but there is more possibility of an exposure to the individuals who are using it. So that's why you need to have a thyroid shield and a body shield as well. As I mentioned earlier, the scatter also causes fogginess on the film. For that, we use the grid. And secondly, whenever you use an X-ray, you have to, or your assistant should cone that beam to the restricted area, wherever it is needed. I mean, if you increase the cone and you expose a larger area, you are unnecessarily giving dose to the patient, At the same time, you have a more scatter and more exposure to your body as well. But if it is a collimated beam, you only expose that area that is needed. You have a less scatter and less radiation to you as well. So this is a grid that is used basically to remove the scatter image, and it helps you in getting a good image. Radiation protection principle, that X-rays, like you can advise an MR, you can advise an ultrasound without any reasonable justification, but X-rays should always be judiciously used because these are ionizing radiation, these carries significant side effect. Always used to have a best quality image, collimate the area, focus the area, so you don't get unnecessary exposure and a good quality image. Naturally, the rule is as low as reasonably achievable, ALARA principle. Dose saving features, there are many intrinsic features in the new machines. As I said, that now they have come up with a dynamic detector instead of image intensifier that has a better image quality with less radiation. You should use a pulse fluoroscopy. Don't put your foot on the pedal always. Use it in a pulses whenever it is needed. Last image hold, this should be, now it is available in most of the machine. Fluoroscopic image storage avoid high radiation to the radiograph. Fluoroscopic image has less radiation, but when you take an image, the static image, that needs a very high quantity of radiation, right? So you should try to have a fluoroscopy maximum and static image as less as possible. This is just to show you that how to wear an apron. You should have a thorax shield and properly stapled apron. Otherwise, this is not a proper way to wear the apron. The radiation can enter from both the sides to your gonad especially. Avoid unnecessary exposure. Always use protective clothing. Use dosimeters. Check tube over and under couch, and then plan your position accordingly. And always use that lead apron. And unnecessary persons should not be present in that room, right? And especially if they are not using the proper protection. Ask your radiographer initially to center with light and collimation and then expose the X-rays, right? At times they are just moving that X-ray by an open tube to point that area. It is better to first identify the area, center it with light, and then use the pulse fluoroscopy. It's better. You can use it with 6 frames per second for most of the procedure, but for stunt you can do it on 2 frames per second. Cone the area so you have a reduced scatter, better quality image. If there is a gas in the duodenum, it is better to suck out because gas adds up to graininess or the poor quality of the image. Always check that your assistant is ready before asking to screen. Stop screening whenever a maneuver is completed, right? You should be vigilant that you remove your foot from the pedal. Good radiograph will watch your eyes. Do not get irritated if they stop screening. I mean, it is better to have a less exposure rather than getting irritated with an extra dose of radiation. Explain to radiographer need for a prolonged screening if required, but it is better to have as less as possible. Because, if you are doing an ERCP on daily basis, this is your profession, there might be a time when you have to stop it just because of this excessive radiation. So it is better to be safer so you can work for a longer time. For patient comfort, do not screen if patient is moving, check wiretap, amount of air, anticipate that dilatation will be painful, so you explain that to that to your patient. Awareness of colleagues' limb, if anyone has to hold the patient limbs so that patient doesn't move while doing the procedure. The conclusion, X-ray should be judiciously used. Always use the protective clothing. Use dose-reducing facilities and communicate well with your assistant, patient, and a radiographer. At the end, I'll just have few more things. As Saad mentioned, I always start selling my cyber knife. Before going to that, I think since all of you are doing an endoscopy training, Probably this is the best center in the Pakistan where you have this facility of endoscopic ultrasound, because along with that endoscopy, ERCP, you need to learn about this technique as well. So it will naturally add up to your quality of work. This is just an ultrasound image of an endoscopic ultrasound. You can see a gallbladder very clearly. This is the liver. This is a longitudinal section. This is an IVC, head of pancreas, and a CBD. This is a CBD with a stone. So ultrasound, at least in my opinion, nowadays, this should be a mandatory part of the suite, because many puncture, many time, even the routine ultrasound can help you. And if it is with an endoscopic ultrasound, naturally it will add up to your quality of work. MR, non-invasive method to evaluate the biliary system. If possible, if available, before going for an intervention, one should have this gross map, so you have an idea about the pathology, what you are dealing is, and what are the possible complications which can occur if you have a broad-based map, right? This is an MRCP image. This is the area of the liver, right, left hepatic ducts, CBD, right? This is some fluid in the stomach. This is the duodenum. This is the pancreatic duct, another gallbladder, right, left hepatic duct, common hepatic duct, cystic duct, common bile duct, pancreatic duct. PET scan is a new modality. I also wanted to share it with those who are serving in Pakistan, that our PET scan start hopefully in 3 to 4 weeks. We'll start our facility. It will be an absolute free facility. There's no charge. Whenever it is needed, you can send your patient for a free PET scan at JPMC. Naturally, this is in PET scan, whole body is covered except limbs. We start from head up to the pelvis. And this is the CT scan image, and this is the gamma camera image. In PET scan, basically, it is a one machine which has a CT scanner and a gamma camera, right? It's a fusion machine. And this is the image where you have a combination of both these. You fuse this image with this, and you have this type of a picture. So this image is very good for the physiological information about the tissue. This image is good for the anatomical localization, but it does not give any physiological information, especially the plain CT scanner, right? So it is a combination where you have both these things. Any value, just one thing for you to remember, any SUV value that has more than 4, right, that is suggestive of malignancy. Less than that, there is a less chances of malignancy, sir. It is enough to remember that when you read a PET scan, read out the value. If the value is more than 4 SUV, right, 4, then it is suggestive of or possibility of a malignancy. So we have a PET scan, and we also have a CyberKnife. We have done around 12 cases, 12 or 13 cases of liver, and we recently did one insulinoma that was probably unresectable. It was referred from Shaukat Khanam by CyberKnife, and the results are comparable to that other available options, right? So in CyberKnife, we basically identify the lesion. We place fiducials, right? These are the fiducials. There's an X-ray image, and then a plan is generated. And after that, the CyberKnife basically perform surgery without use of a surgeon knife. That's why it is called CyberKnife. It uses radiation to perform the surgery. It is not a radiotherapy. This robot is basically competing with surgeon's hand with the help of these radiation, with the help of these very high degree of precision, but using the radiation. So indication in hepatobiliary hepatocellular carcinoma, liver metastasis, primary malignant bile and gallbladder tumor where it is unresectable, and a pancreatic masses. I'll not go into detail of that, but basically any patient who is selected for CyberKnife, these are the gold marker which we have to place under ultrasound or a CT guidance. At times we need your help. We will be needing your help for placement of fiducial in cases of pancreas. In the previous case, since it was at the tail, so we went from the back and we placed the marker. In cases where it is especially in the body or anterior to the pancreatic duct, we'll need your help for the placement of the fiducial. And thank you very much. any question related to X-ray, fluoroscopy, or any other modality?
Regarding the scattering of the wave, so what precautions we need to do?
You have to cover yourself. Use radiation as low as possible. Do not open the fluoroscopy unnecessarily, right? Only push the pedal of fluoroscopy when it is needed. Collimate the beam and cover your body with the thyroid and the rest of the body apron.
The machines also have the option of lace
Yes, yes, every option is there, every level of safety is there. It is up to the end user to basically utilize that facility.
For this insulinoma, let's suppose it's 1 centimeter.
Yeah.
It's in the body of the pancreas. For fiducials, how many you need? Do you need just right on top of it? Are you like at the edge? Or how do you prefer?
Yes, if when patient is breathing, actually it breathes in X, Z, and Y axis, right? So when lung is moving, it moves in X, Z, and Y axis. So for most of the lesions, we need 3 fiducials, whether it is prostate or a liver. But pancreas, and especially for a smaller lesion, now the limitation of fiducial is that ideally there should be 3 fiducials at a distance of 2 centimeter in 3 directions, right? So it is not technically possible to place for a small. So for pancreas, since pancreas does not move in Z and Y axis, it mainly move in X axis mostly. So we place 1 fiducial that should be within the pancreas, right? That might not be in the lesion. That should be within the pancreas, closer to lesion, maybe in the lesion. The rest of the lesion, then for 2 other references, we take the spine as a reference point. So for smaller lesion, for pancreas, we place 1 fiducial, and that is usually good enough.
So it's for the head, I usually put 3. If it's a big lesion in the head of the pancreas,
for any pancreatic lesion, one is good enough to handle the case, right? But if possible, 2 or 3, that is good enough. So we place these other markers outside of a pancreas, or we use spine as a reference point. Thank you very much, sir. Thank you.
Like you should be away from any distance?
You see, yes, if radiation travel in a straight direction and its intensity gradually decreases inversely, if you are away from the source, naturally there is a less possibility of exposure. But at the same time, you have to hold the machine and other things. So the distance, instead of a distance issue, you should be conscious about using a thyroid goggle and an apron. Then with that apron, you are absolutely safe, right? Wherever you move around. But otherwise, yes, strength is inversely proportional to its distance. If you are away from the radiation, it has less intensity compared to a closer radius. No, nowadays we do not put lead in the wall. Anything 9 centimeter of concrete is equal to the 2.8 mm of lead. Lead is only put in the doors. We are not using lead in the wall now. Right?
So what about the dosimeter, the meters that you since we are having a lead apron?
You should use, okay, this is a very good question. At time I've seen people, they place their dosimeter outside of their lead apron, right? It should be in your pocket, right? It should not be outside of the lead apron. It should be in your pocket. And there are various type of dosimeter, TLD markers or individual dosimeters, digital dosimeters are available. You should keep one for yourself, or you can have that cheapest, that cost around 300 rupees, and you can get it tested every month from the PNRA, right? I am member Pakistan Nuclear Regulatory Authority. We are gradually increasing our registration. We are bringing in more and more. We have issued notices to some of the cardiologists in Pakistan that they have to be very, very careful because they are getting the extra dose. So I think this area will also be covered in future. And if nobody has come up to you from PNRA, then I'll make sure that they come explain to you and also inform you about the facilities available. No, NIMRA has nothing to do. It's a Pakistan Nuclear Regulatory Authority that regulate all nuclear installation in Pakistan, including the diagnostic. Since it started few years ago, members were not very active, but now in the last say 2 years, we have increased our membership from 2,000 to 7,000 centers, and we are coming up with the options and more safety features. Anything that is affordable for you. You can buy your own digital dosimeter, or that TLD batch is good enough. Right?
In fact, it's, nowadays for us it's a requirement to use both outside and inside.
That's a good. So the inside is basically your monthly dose,
Yes.
and the outside batch, if you can afford, you can have an outside batch. So that gives you the day or daily basis exposure, right? So if you get an extra dose, you can be more cautious, right? So ideally, yes, you should use that extra dosimeter, but that is your monthly and annual quarterly dose. That's prescribed figure, right? It's 0.5 millisievert per month, and then there is an annual and a lifetime dose. Okay. Thank you very much, sir.
Unfortunately, Dr. Tariq has to leave because of his commitments. So may I request Professor Said Qureshi to please present a memento of appreciation to him? Thank you, sir. So now our next lecture is ERCP indications and complications. Dr. Bakar.
नहीं मेरे ख्याल उसके पास होता है लेकिन कर रहे उसमें है इसका उसमें चेक करने ये हो सकता है